Before we get into the mechanics of the presentation, it's important that the audience is aware that we have no financial conflicts of interest. There's no financial disclosures that Eugenia, Brandt, or I need to make the audience aware of. Now, we selected this particular topic because it's a growing issue and it's still widely misunderstood. But the other reason that we selected it is because it touches on all of the various aspects of our advocacy and government relations operation. It gives the opportunity for you to hear about how we interacted with other medical specialty societies. It also gives you the opportunity to hear about how the issue is dealt with on the state level and how it's becoming even more pressing on the federal level. This particular presentation hopes to accomplish 5 specific objectives before we open it up for the discussion. First, we'll provide a general overview of the mechanics of surprise bills. We'll outline ACR's position on surprise bills and the activity with the other medical specialties. We're also going to discuss the nexus between the push for greater price transparency, network adequacy, and efforts to combat surprise medical bills. The way we'll do this is we're going to highlight some key advocacy efforts that have already taken place on the state level. You can see the various states that it has become a hot topic below. And also, I'll get the opportunity to speak to you a little bit about some of the emerging efforts on the federal level. We'll highlight how the surprise billing topic has emerged in the calendar year 2019 inpatient rule, hospital outpatient rule, and Medicare physician fee schedule rule. And we'll also talk about ACR's response to that particular rulemaking cycle. And hopefully this will then provide enough fodder for a great discussion. So, in all public policy issues, language matters. How the topic is framed is a key way for how public policy officials will interpret the issue. And this particular topic of today's Journal Club is no different. What we're here to talk about are surprise medical bills. Now, obviously, this is how public policy makers and the insurance companies want us to understand this particular issue. And while most people typically enjoy a good surprise, no one enjoys a surprise medical bill. And so ACR has really taken it on ourselves to try and redefine the nomenclature surrounding this particular topic. But this is how the general public understands this particular issue. So what is a surprise medical bill? Well, it's a medical bill that results from providers, which includes physicians, hospitals, outpatient facilities, laboratories, even beyond that, that patients reasonably assume would be in network, or in other words, they think that their insurance company provides coverage for the services at hand, but they're actually out of network. But it also describes when patients have no real choice over the network status of their particular provider. Now, surprise bills are found in a variety of situations, including emergencies or visits to the ER department for non-emergent conditions. The other example that you'll hear about a lot in the press, and we're here to talk about as well, are surprise bills that stem from ancillary specialists. Those include anesthesiologists, pathologists, and yes, radiologists. The other thing too that you'll hear about are inadequate physician networks that are offered by the insurer. Finally, you're also very often will hear about patients with high deductible plans, and this isn't really a surprise bill, but in other words, with a high deductible plan, you as the patient have assumed a larger out-of-pocket cost, and as a result, when you get care that may not actually be covered by the particular deductible, you are suddenly stuck with a larger bill. Now let's take a moment to discuss the intricacies of these surprise billing scenarios. With the emergencies, you often hear about patients suffering an emergency where they're unconscious or they're incapacitated and the ambulance takes them to a hospital that is out of network. This is very common, but we'll also hear about patients who suffer an emergency and they're taken to an in-network hospital for care, yet the emergency department is out of network. So the first example here is very egregious in the sense that the patient really has no choice. The ambulance either needs to take them to the facility that's closest to them or to a facility that is most properly equipped to deal with the clinical condition. We also hear about ancillary specialists providing patients with surprise bills. And the patients receive the care at an in-network hospital, but their radiologist, their anesthesiologist, their pathologist, or even a surgical assistant are actually out of network. And this is applicable either for planned or unplanned care. The example that you most often hear about is a patient who has a planned surgery. They go in to an in-network hospital and even their surgeon is in-network, but a surgical assistant will come in, provide additional assistance. They are not part of the beneficiary's insurance network, and all of a sudden the patient is hit with a large bill. Similar circumstances apply with radiology services, anesthesiology, and laboratory services. Again, though, language matters. And we would argue that these are not exactly surprise bills. With the exception of some of the emergency situations, the college basically feels that these are more accurately described as surprise gaps in medical coverage. In other words, the surprise bills largely stem from the actions of the insurer. Now, too often, surprise medical bills are the byproduct of the actions of the insurer. And for example, the insurer simply has an inadequate number of physicians, especially ancillary physicians, or they utilize an out-of-date listing of providers. So the patients, they need care, but they simply can't find the physicians in network to treat them. We've seen this in an acute way with cancer patients. And when we describe the out-of-date directories, what we're talking about are providers that are not accepting new patients, or they have excessive appointment wait times, and essentially that makes them a de facto out-of-network provider. But we also see examples where a patient has to travel large geographical distances just to access the care that they need, and it's largely prohibited for them. The most egregious example of the out-of-date directory is when they list deceased members. Now, the dermatologists have done a great job with a secret shopper analysis, which was published in JAMA Dermatology several years ago, which described how these narrow insurance networks would offer lower premiums and still maintaining what is believed to be a robust provider network actually has a variety of deceased physicians in network. So the dermatologists did a great job highlighting the issues with that. We also find, though, that the insurers they'll refuse to offer meaningful reimbursement for the physicians, and that basically forces the beneficiaries to accept out-of-network care. And it's the insurers preying upon the patient's limited knowledge of insurance and the desire for cheap premiums. They get a cheap premium, they get what they think is a robust coverage plan, but in reality, when they go to get the services that they need, they find out that their particular insurance plan is not providing the adequate coverage that they need. And it's important to note that these insurer scenarios are probably equally, if not more common, than the emergency or the ancillary service situations that I described in the previous slides. So we think it's an unfair characterization to describe these necessarily as surprise bills, and they're more adequately described as surprise gaps in insurance coverage. So why are surprise medical bills more common today? Well, I can offer a variety of reasons to explain this particular circumstance. First, we've seen an increase in the growth of high deductible plans, and we've also seen amongst those folks that have high deductible plans ever increasing deductibles. Under a high deductible plan, you as the beneficiary assume greater financial responsibility for the out-of-pocket costs, and therefore sometimes you are forced to cover the cost of the services that you think should be covered by your insurance plan. It's not necessarily a surprise medical bill, but beneficiaries, the press, and public policymakers oftentimes characterize them as surprise bills. We've also seen the growth of narrow networks. This is a byproduct following the passage of the Affordable Care Act. We've seen it in the individual market, which describes individuals who receive their health insurance outside of the employer. They have to pay for it out of pocket or through the ACA insurance exchanges. We've also seen consolidation among hospitals and specialists, which allow them to exert more market pressure over insurers. They no longer are bound to accept paltry reimbursement rates because of the fact that they've consolidated and have greater market pressure. Now I'm going to turn it over to my colleague Eugenia, who will cover the ACR's position on surprise medical bills. She'll talk about our work with other specialties on this topic. She'll also highlight advocacy efforts in key states and describe some of the other key terminology related to this issue, which will help your overarching understanding of surprise medical bills. Eugenia?
Thank you, Chris. Radiology is certainly not alone. There are many hospital-based specialties that are impacted, so there's definitely an opportunity for coalition building. In addition to radiologists, ER physicians, anesthesiologists, and pathologists are most commonly affected by this issue. And at the state level, you will find yourself working with your colleagues from other specialties because you will need the strength in numbers. Insurers are quite a formidable enemy, and they are throwing a lot of money into lobbying on this issue. At the national level, me and my counterparts, we talk quite often about what's happening with our respective societies and some of the trends that we're seeing at the state level. So about 3 years ago, the various national societies got together to brainstorm on the issue of out-of-network billing, and how we can all work together. So at the time, we had agreed that it will ultimately be our respective chapters that make the call on what solution is best for them and in their political circumstances. But we wanted a rallying line in the sand, so to speak, something that perhaps unites us all, or something that we can agree upon and hold a united front as much as possible when we address legislators. So at the time, the groups agreed to both a collection of key policy principles and acceptable proposed solutions. In the key principles, we had discussed holding the patient harmless in true emergency situations, and otherwise requiring the insurer to have the responsibility to better educate beneficiaries about gaps in coverage and lack of in-network specialty providers. And key solutions, proposed solutions, is in lieu of balance billing, basing out-of-network reimbursement on 80th percentile of Fair Health database, something I'll talk about in a second, or permitting the physicians to pursue ADR, alternative dispute resolution, between plans and providers, so a type of mediation that can occur in a true balance billing situation. It was essentially lowballing provider cost of services because they were manipulating the data, and as part of the settlement, United and Ingenix funded a nonprofit healthcare pricing database, Fair Health, and it's over the years become almost a gold standard for pricing. Many government entities use it because it has insurer data both from private insurers and Medicare. And we know that the insurer plans use it in establishing out-of-network benchmarking, because we have seen documents from United and I think Aetna where they benchmark out-of-network services for their providers at 80th percentile of Fair Health. Chris gave us some of the scenarios where true balance billing can occur, but regardless of who's at fault, surprise bills do force patients to pay higher costs. So they either have higher copays or they have to pay for the full cost of services without credit towards out-of-pocket maximums or deductible maximums. And when this does happen, the patients are seen as the victims because the bills are often exorbitant, and patient advocates feel that they are in the middle, and there is a larger tug of war between the providers and the insurer community. And the legislators respond to that. Both at the state and federal level, policymakers are looking at various proposals to see how this issue can be addressed. You will see that many of the proposed policy solutions to surprise billing include some form of enhanced transparency provisions. It may be educating patients about their insurance coverage or out-of-pocket costs. It could be placing limitations on geographic travel, but as physicians and working in hospitals, a treating physician may not often know the nuances of one's health insurance coverage, and transparency does not address emergency situations. We also have a lot of talk about informed consent, but for a radiology practice that may or may not be housed within the same hospital building, obtaining informed consent should not stand in the way of the patient receiving medical care that they need in a timely manner. Banning balance billing is really something that we see a lot, and I think the concept resonates with the state legislators because they feel that if a patient presents to an in-network hospital, of course they should not be incurring out-of-network bills, or at least should be notified about out-of-network care that they may receive, and the insurers, unsurprisingly, are very supportive of this proposal. Additional proposed solutions to surprise billing include treating all out-of-network care as in-network. In this instance, patient would only pay in-network cost sharing for out-of-network care, but insurers would only be bound to reimburse providers at in-network rates or at a percentage of Medicare rates. And this already applies to ER services on the federal and state level, but not really to ancillary physicians. The weakness of this proposal, of course, is that it does prevent physicians from leveraging better payment from insurer and may lead to access of care issues. Another proposal is to require the health plans to pay the difference in costs for treatment rendered. Hereby, patients would only pay in-network cost sharing for out-of-network care, but the difference between the negotiated rate and the actual cost will be borne by the insurer. And of course, the weakness of this proposal is that it prevents insurer from leveraging lower costs from physicians, and the insurers are very actively arguing against this proposal by saying that this will drive up the premiums and costs for the patient. We have seen proposals to require in-network hospitals to force ancillary providers to accept in-network rates, and of course we know that there are state laws that protect providers from coercive contracting, and hospitals may encourage their providers to be in-network and to accept the same set of insurers that the hospital is in network with, but to require in-network participation from providers, we felt was going a step too far. There are also proposals to amend the federal law so the balance billing provisions apply to ERISA or self-insured plans. Currently, balance billing solutions at the state level, they impact only the non-ERISA plans. Therefore, a big chunk of the market is not affected by state regulations at all. I have alluded to this paradox a little bit earlier, but consumers are really aligned with insurers on the issue of balance billing, and the graphic is about the tug of war that I mentioned previously. The constituents go to lawmakers and they really push them to seek a ban of balance billing. 21 state laws already offer some degree of balance billing restrictions on consumers, but we really feel that here is where patient education is key. There really needs to be a change in narrative between what is a surprise billing situation and what is a surprise gap in coverage. Not surprisingly, when we discuss this issue, network adequacy gets brought up a lot, and I think the issue here is if the regulators were to force the insurance plans to sell a product that includes an adequate network, then perhaps the issue of out-of-network billing goes away. And I've already touched upon some of the transparency provisions. In terms of minimum standard benchmarking, what we are seeing is tying the out-of-network reimbursement to a charge database such as Fair Health. We've seen proposals to tie out-of-network reimbursement to a percent of Medicare. In California, the number is 125%. We have seen proposals to tying it to in-network payment, the greater of 3 that I had discussed a little bit, and a new one or a recent addition to the deck is a percent of allowable charges. This is something that is heavily favored by insurers, and that is of course because a percent of allowable charges is a dollar figure that is entirely controlled by the insurers. And in this instance, if you are forced with a proposal on a percent of allowable charges or no benchmarking at all, then the radiology perhaps should take a hard look and see if not having benchmarking specified is really the better solution, and perhaps introducing something like alternative dispute resolution into the mix, so some form of mediation versus arbitration. I'm going to hand it off to Chris here shortly, but really I wanted to leave you with a list of resources. We're here for you. Your state chapter is probably very involved with any negotiations that take place at the state level. The AMA state medical societies or the individual AMA state chapters will be very involved. They do have a model bill and a brief on out-of-network billing. There is also a group called Physicians for Fair Coverage. It is a nonprofit that was created earlier this year, and it is an advocacy group that is dedicated entirely to the out-of-network issue. And another good resources that I just quickly want to highlight is TMA's white paper. Texas has done a lot of work on this issue and has a lot of good information. But first and foremost, please remember that when this comes up in your state, reach out to us and we're happy to talk you through any particulars that or any questions that you may have. And I'll hand it back to Chris.
Thanks, Eugenia. As you just heard, surprise bills are largely dealt with at the state level, and that's because they largely emanate from private insurance. So that has provided few opportunities for the federal government to take an active role in regulating surprise bills. This, however, may be changing, and we may actually be witnessing something right before our eyes, a turning point. And this is due to the fact that all 3 key payment rules have attempted to gather requests for information on price transparency and surprise bills. The three rules in question are the inpatient prospective payment system, which deals with the hospital inpatient visits, hospital outpatient prospective payment system, which deals with hospital outpatient departments, and the Medicare physician fee schedule, which deals with the physician office setting. All three rules for the calendar year 2019 included some sort of information related to price transparency and surprise bills. In particular, the preamble for all these rules call out the lack of transparency as potentially one of the causes behind surprise bills in Medicare. And the preamble, which describes the various policies and the background analyses related to the policies, actually call out anesthesiologists and radiologists as a key factor behind surprise medical bills in Medicare. This is a little strange that they're talking about Medicare in a sense that we would argue this is primarily an issue as it relates to private insurance. Nevertheless, the policymakers use these rules to try and get after the issue. So what did these various payment rules seek to enact, and how did the college react? Well, the inpatient, the hospital outpatient, and the Medicare physician fee schedule rules all indicate that hospitals are currently required to make a list of their charges easily accessible for patients. If a patient wants a better understanding of the charges before they receive the care, the hospitals are required to make that available to the patient. Typically, they can provide either the charge master or some variation of. The inpatient rule finalized a new proposal to require the charge list to be available in a machine-readable format, or in other words, computer accessible. And so that was the primary thing that the inpatient rule decided to enact. The HOPS and the Medicare physician fee schedule rules only asked questions on price transparency, and they really didn't get into any sort of details as it relates to surprise bills. Now, the final rules for both of these regulations are expected in November of 2018, so things may change between the proposed and final rule, but based off of what they initially were asking, we don't expect that. Nevertheless, the ACR took umbrage with the notion of surprise bills in the Medicare rulemaking cycle for all three of these rules, and our comment letters focused on the following aspects. We expressed support for hospital charges in machine-readable format. We pushed back on the phraseology of surprise bills, utilizing the same concepts that I described earlier in the presentation. We highlighted how surprise bills are an issue within private insurance, and they don't really affect Medicare. And our final conclusion was essentially that the federal lawmakers need to defer to the states when seeking surprise bill regulations. So why did the ACR argue that there is no such thing as a surprise bill in Medicare? Well, Medicare classifies practitioners into three categories: participating providers, non-participating providers, and opt-out or private contractors. 95% of the Medicare providers are classified as participating providers. These physicians must accept Medicare reimbursement as payment in full for all patients. They have to collect the payment directly from Medicare. They cannot bill the patient directly. And the patients have cost-sharing protections applied to them. Patients are guaranteed not to be charged more than the fee schedule amount, nor will they face higher out-of-pocket cost-sharing above the standard 20% coinsurance. So if 95% of participating providers are classified as participating providers, then you really have no circumstances where surprise bills present a serious issue. To be fair, there are non-participating providers, and it encompasses 4% of Medicare providers. But the terminology non-participating provider is somewhat unfair. The reason for that is these individuals only receive 95% of the Medicare payment reimbursed to participating providers, and they can only balance bill patients based off payment rates that are no more than 115% above Medicare's established fee-for-service rates. So they really do participate in the program. They're just classified as non-participating providers, and they're only allowed to receive 95% of the Medicare reimbursement rates. The patients continue to have cost-sharing protections as well. They're only assessed 20% coinsurance, and that too is based off the 95% of Medicare's established fee-for-service amount. Less than 1% of providers are classified as opt-out or private contractors, and of that 1%, radiologists and nuclear medicine physicians only comprised 0.1% of the total. These individuals are truly not bound by Medicare's physician fee schedules in any way, and they are free to balance bill for the entire cost of the service. With patients, They have to sign a contract before they accept this type of care from an opt-out provider. So they're really not surprised. They're fully aware of what's happening. So this was the key point that we made to the federal government in all three payment rules. One other thing that the ACR did in conjunction with other medical specialty societies as it relates to the three Medicare payment rules is we co-signed an American College of Emergency Physician-led group comment letter in opposition to the idea of surprise medical bills in Medicare. This comment letter continued to express support for not using insurer-based usual customary rates or Medicare payments as the benchmark for out-of-network reimbursement. It highlighted how EMTALA and the ACA's greatest of three rule hurts the emergency room physicians' ability to negotiate better rates. And we had also highlighted the benefits of the Fair Health database. Again, a little more of an ER-centric letter, but it still highlights many of the key aspects of surprise bills, in particular the benefits of Fair Health database. So we've come to the end of the presentation. To stimulate the discussion, we wanted to provide some additional questions to hopefully provoke you all to become a little more engaged on this particular topic. The questions include: have you experienced issues with local insurers that necessitated your radiology practice to be out of network? If so, how do you attempt to mitigate surprise bills? What are your views on supporting legislation that attempts to mitigate the impact of surprise bills via Fair Health databases or alternative dispute resolution? Should the patient be held harmless in all surprise billing scenarios? And how can radiologists become more active in the surprise billing advocacy debate? If you have any experience within your particular state related to surprise bills, we'd love to hear from that. We appreciate your attention to this particular topic. We look forward to the discussion, and we're happy to answer any sub-questions that you may offer following the start of the open discussion. Thanks again.
In discussions about the minimum benefit standard, or MBS, we often talk about benchmarking of Fair Health database. Basically, Fair Health came to be in 2009. There was an investigation of the Ingenix database in the United Health Group, and the investigation found that Ingenix database